Tenderness over posterior. Look at that posterior testis, upper and posterior testis. So by the symptoms, you should know where the problem is. Is that clear, folks? Upper and posterior. What is Friend's sign? Pain relief with scrotal elevation. So we ask the patient to elevate the scrotum and they say it feels better. So that's the Friend's sign, folks, okay? It may progress to involved testis, but it's not. That's epididymitis, very common. Orchitis, it's a problem of the testis. Inflammation of the testis. Whenever you talk about orchitis, what should come to your mind? Mumps orchitis, folks, okay? Kids, these males get mumps as a young age, but when they grow, they are possibly at infertility risk, folks, okay? So that's mumps. So orchitis, epididymitis. Look at this. If it is epididymitis and orchitis infection, see trichomatis and gonorrhea in the younger people, E. coli and Pseudomonas otherwise, folks, okay? Those are the epididymitis and orchitis. Are we clear, folks? All right. So that take care of that. Now next, prostate. Now, before we learn prostate on that, I kind of want to show you something. I like this picture just for understanding. This is the old first aid. I like this diagram. Okay, let's take a look here. Now that's a cross section of the prostate. Okay, after we learn this, we will move it to this one, but this is better first. Now here, I'm going to tell this is the posterior of the human. This is the anterior part. Okay, that's a posterior and anterior part, folks. Now, if you see in prostate, we have anterior lobe, and then we have big two lateral lobe. That technically lateral lobes are the biggest one. Is that clear, folks? And then you have a middle lobe and a posterior. I'm going to highlight posterior lobe. In this picture, if I tell you this is 12 o'clock position, 6 o'clock, 3, 9 o'clock position, where should I put rectum in here? Where should the rectum be? Type it, folks. Where should I put it? It should be at 6 o'clock position. So the rectum is somewhere here, for example. Is that clear, folks? Now, why this is important to know? I'm not just asking randomly to you guys. If you know the anatomy, disease becomes easy. If I ask you, what lobe is right next to your rectum? It's your posterior lobe. Is that clear, folks? When you do a digital rectal exam on a male, which lobe are you actually feeling? Posterior lobe. Is that clear, folks? That's why we see it, right? Now, when you talk about BPH, benign prostatic hyperplasia, right? What's happening? All this gland is enlarging, right? When the gland is enlarging, they are squeezing the urethra. The urethra is in the middle, they get squeezed up. Is that clear, folks? If they are squeezed, do you think this male have an easy way to urinate? No, right? Look at this picture now. In here, that's a urethra. And then you have the glands, folks, okay? Now, here, the picture is not even shown properly. This is where the rectum is posteriorly, okay? That's where the thing is. So you should know whenever people have BPH, the urethra is completely constricted. Is everybody clear, folks? Let's read about BPH. Common in male, more than 50 years, characterized by smooth, elastic, firm nodular enlargement in transition zone, which compresses the urethra. Makes sense. It's a urethra. Often presents with increased frequency of urination, nocturia, difficulty starting and stopping, because it's compressed in the middle, folks, okay? It can lead to distension and hypertrophy of the bladder, hydronephrosis, which makes sense because the urine is backing up on both sides, UTI, all these things are possible. We could measure in the blood increased total PSA, or you could do fraction of free PSA as well, folks, okay? What is the treatment? We give alpha-1 antagonist. If you meet anybody more than 65-year-old male, most likely they are taking that medication. It's like the ibuprofen, they have to take it, okay? And if not, we give 5-alpha reductase inhibitor. 5-alpha reductase inhibitor is your finasteride. Why do we give 5-alpha reductase? It inhibits the conversion of testosterone to DHT. DHT is important to develop. What are the 3 structures? Type it up. External male genitalia, right? What are the 3 structures? Okay, prostate, penis, scrotum, all those things. Don't forget prostate, okay? That's the idea, folks. Now, if the treatment doesn't work, we do something called TURP procedure. It's a surgery, transurethral resection of the prostate. So what they do in that surgery, just to let you go, they go around and they cut it out and take it so it makes the compression to go away. Is everybody clear, folks? So that's that surgery, okay? Now, that's BPH.
Dr. Roy, I had a question. I had to observe a TURP one time, and I was wondering, why do they go through the urethra and not through the
rectum? Yeah. If you go through the rectum, you are getting into the posterior lobe. There is no way to go there.
Okay.
Yeah. So that's why if you want to get into the lateral lobe, any of those things, you have to go through it. Okay. Now,
Dr. Roy, are there still like I've been told that at one point at least there used to be like a lot of complications with these TURP procedures, like nerve damage and like high risk of that. Is it still the same, or is it improved?
It is, yeah, but then remember, see, that mostly these people who goes through these procedures are like 65 and above. By the time they experience complication, they might not be alive. Okay, and there's so many procedures they do in the hospital every day, and like, sometimes like 8-10 of these, they might, not everybody, and of course it play a role of the doctor who's doing, how much experience they have, but there's always some people have complication, but I don't know how much severe in the post. Sometimes the complication can come after 5 years. At that point, they are 70. If they were to have a diabetes, they have a peripheral neuropathy, they won't even feel anything anyway. So, you have to look into the big picture on that.
So they're not immediate complications. This complication.
No, not immediate complication.
Okay.
It all takes time. But unless the immediate complication happens, is the doctor is really make a mistake when you do it. Okay. So that's the idea. Okay. But most of them, like, some people don't like the medication. That's why they go for it. But if you take a 5-alpha reductase properly, you shouldn't have a problem. It does quite a good job on that. So that's BPH. Now, let's talk about prostatic adenocarcinoma. Now, look at this, folks. Most of the time, the cancer comes from posterior lobe. Look at that. That's why I like this picture. It's very easy to feel the cancer on the prostate gland with the digital rectal exam, then feeling the BPH. Is everybody clear, folks? First of all, you will learn rectal exam when you do medical rotations. It's so hard to feel it, folks, okay? We were told that if you feel when you do rectal exam like a rough area like this, that's BPH. If you feel like a knuckles, nodules, that's prostate cancer. That's how you feel it, right? I did about 100 rectal exam, cannot feel a thing in there, okay? I didn't feel anything. The reason behind, the sphincter is already constricting your finger when you're doing a physical exam, by rectal exam. So it's so hard to feel the sensation, and you cannot do it for a long time. Patient gets angry, right? You have to go in and out. So if I cannot feel, I used to tell in the rotation, it looks normal, all good, right? But then, of course, you don't do that, but it takes time. But the idea is, it's so easy to pick up prostate cancer on a rectal exam. That's why they say everyone, old age people should get a rectal exam, just to exclude, because prostate cancer is pretty common for elderly people. And then if they get it, it's nasty. Okay, it's very important. So some people, they don't. Now, a quick story is, if you ever come to Mount Sinai Hospital in Chicago, you might get a rotation. Anywhere you go to Mount Sinai, Chicago, you will see a picture of a person. He was the chairman of family medicine in that hospital. Why they have their picture is, he changed that hospital into a different level. He's considered like a hero of that hospital, okay? He was very famous, and he did so much good to that hospital as a physician. He died of a prostate cancer at young age in that hospital because he wouldn't allow anybody to do a rectal exam. He never did a rectal exam. And because, the idea is it's a simple thing that creates a bigger problems. Does that make sense, folks? So that's the idea. But always remember, when you do digital rectal exam, you feel posterior lobe. That's right next to it, okay? That's why I like this picture better, but now we could go there, folks, okay? Now, prostate gland and is most frequently diagnosed with increased PSA with the biopsies, folks, okay? Now, histology is there graded using Gleason grade. There's a way to do that. And then we, of course, closely check for any metastasis. There's a prostatic acid phosphatase, PAP, and PSA are useful tumor markers. Highlight. Osteoblastic metastatic bone. Remember, we studied this when we did multiple myeloma. Multiple myeloma is osteolytic lesion due to osteoclast. So the bone looks thin. Prostate cancer, the bone looks thick. Remember that? With the osteoblastic lesions, okay? Very important. People get also lower back pain, right? That's the whole reason we were talking about this, okay? Because it spread to the vertebral bone. Now I could ask you, how does it spread? Through the vertebral venous plexus, we call Batson plexus. That's how it spreads, okay? So that's the idea, metastasis of that prostatic adenocarcinoma. Now, next one, prostatitis. That's an inflammation due to infection, characterized by dysuria, frequency, urgency, low back pain, warm, tender, and enlarged prostate. Now, especially when you talk about acute bacterial prostatitis, it's one of the painful infection, folks, okay? The people struggle a lot on that. It's in older male. Most common bacteria is E. coli. Young people, STI, sexually transmitted infection, okay? Now, acute bacterial prostatitis, you will be surprised. We have to give antibiotic plus NSAID. Because a very bad inflammation, you have to, how long we give the antibiotic for? 28 days. They have to take a 1 month almost of antibiotics, especially ciprofloxacin, and it's a very strong fluoroquinolones. They have to take it. Why? It's very hard to get a medication into prostate gland. So that's why we keep it for 28 days for infection, NSAID for inflammation. Okay, so that's there. Chronic prostatitis is either people are not treated properly. Remember, nobody wants to take antibiotic for 28 days. That means these people cannot drink alcohol for 28 days either, right? So they feel better after 10 days or 12 days, they stop it and they go back. And then after 2 months, they come with the same symptom. We call chronic prostatitis because that was not treated completely. Or there is something, other nerve problem or chemical issues. Is everybody clear, folks? So that's prostatitis, okay? Now, that's an important part here, folks. Any questions so far? Let's see if I have question in this. I do. Let's go. Diagnose first. Okay. 18-year-old man comes to the office due to 2 days of right testicular pain. The pain is constant, exacerbated by movement. Vital signs are within normal limit. Physical exam, there's a swelling of tenderness and palpation localized to the posterior and superior area of the testicle. You see, now you should appreciate the anatomy, right? That should be epididymis that's involved. So that should be most